deep into the presentation until everyone arrives. As you all, I think, are aware, tonight's talk is about osteoporosis and osteopenia for that matter, which is obviously the precursor condition. My name's Chris. Chris Andreano. I think a lot of you know me. I'm sure many of you don't know me. I've been at St Leonards Physio for quite some time, and running our osteoporosis program specifically for a number of years now. I think some of you have been through St Leonards Physiotherapy in the past. Some of you might not know us very well. Um, the osteoporosis program we run, it is affiliated with the Bone Clinic, which are the organisation that established Onero, which is the exercise program itself. We'll get into these things in a lot more depth as the presentation goes along. My background is a physio, and I was actually an exercise physiologist prior to becoming a physio. So that's kind of where my expertise sort of comes in regards to the exercise part of this condition. So a little bit about me. I think some of you know me quite well. We can just shoot that out of the road. I've been at the practice for coming up on 9 years, I think. This is my 9th year at St Leonards Physio. As I said, I started out in an exercise physiology course and a diploma of exercise rehabilitation down in Wollongong. And then that kind of led me a few years later into physiotherapy. I sort of wanted to add a little bit more to my, I suppose, my skills and expertise, and sort of physio is a really good adjunct to exercise physiology. So together, I think they go quite well. I've got my hands full with 2 young daughters. My eldest is 3, and my youngest is coming up on 1. So life's pretty busy in that regard. It's very different to what it used to be, but it's extremely busy in a really good way. That's a pretty cheesy picture there on our website of me, but that's I'm looking a lot younger, and that was well before any children came along. So I thought I'd throw that in as a bit of a laugh. My interests are currently always been in sport, really, but currently in golf and in running. A little bit about me that you might not know is I love going on trips like this one down here, where a bunch of friends and we like to sort of organise a yearly trip where we go and play golf in really nice and amazing destinations, and this is one of them down in Tasmania. And I just really loved this picture, sort of us sitting around the green at the end of the day, yeah, after a big day of golf, and really sort of soaking in a really nice sunset. But um, yeah, that's kind of part of what I do in my spare time beyond my work as a physio. And I love running, so I've been sort of running a lot more in recent years. This is me last week in the half marathon, where I sort of ran for 20 k's, and I regretted it for the next 5 days afterwards. But yeah, from my passion for running, I've also started to see a lot of runners with injuries. So it's been a really good sort of progressive thing for me in regards to my passions. But beyond that, beyond running, I also like to help people out who have tendinopathy and bursitis, which are conditions that tend to go together. Osteoporosis, which we're about to get to, osteoarthritis, which is very different, but people sometimes get those two confused. And I do like to help people who have more persistent or chronic pain problems. So just a little bit about me, obviously there. I hope that gives you a little bit of background of me, yeah, particularly if you haven't met me before. So let's get going. A little bit about our practice. We're on Atchison Street. This is our shop front window, really, on Atchison Street. We're pretty good sized practice in that we deal with a lot of different things when it comes to physiotherapy. Obviously, pain and injury is a key part of our work generally. Sports injuries, pediatrics, which sometimes people don't realise we deal with, pediatric physiotherapy. So seeing children and adolescents, and even babies, newborns, even with various problems that can arise. Raquel is our primary physio there. And of course, our chronic disease exercise programs, which Onero, which we'll talk about tonight, is a key part of our programs, alongside some other conditions, osteoarthritis, diabetes, and group therapy, which we run, which is a little bit more to do with pain management and improving people's sort of strength and well-being. And finally, physios are often available just for health and exercise advice, which I think people sometimes forget in that we are quite yeah, we're quite capable in that sense, and it doesn't always have to be on the background of a problem, I suppose. So I think that's I think that's a really relevant thing. Now, one moment, please, everyone. Never mind, it's all good. So let's get into tonight's talk. We're obviously talking about osteoporosis. The cause and the impact of the condition is obviously key in terms of why we really need to try and improve things and address the problem. We're going to get into bone anatomy specifically and how it responds to loading. Diagnosis of osteoporosis and osteopenia. Some of you have a good awareness of this already, having been diagnosed. Some of you may not be aware and eager to learn. So I'll sort of go through that from the beginning. We're going to touch on the research. So certainly, certainly, there's a number of trials that have been done for osteoporosis when it comes to exercise, and I'll certainly get into the most important ones. And everything's being constantly evolved in that space, and it's really exciting and promising. We'll talk about treatment, including medications, which we get a lot of questions about. Medications are obviously a big part of the management of the condition, but are certainly not the only management option. And that's what it'll lead us. That'll lead us gradually into exercise and Onero, and we'll talk a little bit about specifics of what works and why. So moving right along, anatomy of bone. So this is a femur. So this is our thigh bone, okay? And over here we have a vertebral body in the spine. So this looks like a pretty medium-sized vertebral body. It's probably the thoracic spine, I'd say. So the thoracic spine is the middle portion of our back, whereas the lumbar spine is the lower portion, and the cervical spine is the neck and upper portion. So this looks like a medium-sized one. And you can just see that there's some different layers of bone. So if we go to the femur, you can see there's like this sort of outer stiff sort of layer, and it's quite thin, really, but it's quite stiff. It's stiff, but it's thin, and it's called the cortical bone. And all bones have this sort of outer layer. They have quite a good direct blood supply. And then within bones, we have this kind of lattice type structure, which is called the trabecular bone. And this is quite relevant. It's got less of a direct blood supply, but it does get a lot of high nourishment from the bone marrow, which you might have heard of. And it gets more turnover actually than the cortical bone. Okay, so we do get a lot of bone turnover, which we'll talk about in a moment, which is really key to osteoporosis, is the actual turnover of bone and how it changes with various physiological situations. It's worth noting that trabecular bone can withstand higher strain, so various forces and directions applied to the bone, the trabecular bone withstands a lot of those forces. And when we see osteoporotic change, it's often in the trabecular bone, which is what sort of precipitates fracture risk or increases fracture risk, which is really what we'll get to, is a key part of reducing the risk of fracture. That's really what we're all about. Bone is anisotropic, so it is load versus direction dependent. So depending on how forces are applied to the bone, that'll really dictate what occurs in regards to overload or fracture risk. So the direction of the force is really quite important. So compression is sort of more of an inward force where things are coming together, whereas tensile forces are more of a pulling apart. And shearing forces, as we all sort of know, are sort of like when there's an opposite direction of force. Okay. So, and that can be in various directions. It's not always, totally opposite, but it is quite relevant. So our bones can withstand a lot more force if it's compressive versus tensile versus shearing force. So a lot of fractures occur with shearing forces. So in sport, for example, you'll often get a high energy moment where the bone might be traveling in one direction, and then there's a rapid force applied in a somewhat opposite direction, say an opponent in a tackle, and that can lead to a fracture. And in that scenario, you've got quite a high energy moment, which is driving that fracture. But it is relevant in the sense that shearing forces are a problem, and even if someone was to have a fall from a standing height and fracture their hip, that involves that's called a minimal trauma fracture, which we'll get to, which is essentially one of the diagnostic criteria for osteoporosis is a minimal trauma fracture. But even if you fall, there's a degree of shearing load as you land on the side of your femur because you've got force from the ground and then you've got the weight of your body going the opposite way. So that's creating that shearing impact through the neck of the femur, and that's what can lead to some horrible fractures and horrible consequences following. So we'll get into the trabecular structure a little more later, the TBS score. That can be a better indicator of fracture risk than bone mineral density. Just to wrap that slide up. Osteoporosis as a condition is primarily characterized by compromised bone strength, which predisposes to an increased risk of fracture. So it really is, that's its label in the sense that it's quite a simple diagnosis, or I suppose a simple definition, but it has quite complicated physiology and and origins. So really, it's bone mass and mineral content. So you've probably heard of calcium. That's a key part of bone mineral content. And yeah, as that bone density goes down, as we all get older, that's kind of what osteoporosis is based around. It's quite high. So 1.2 million people have osteoporosis, and a further 6.3 million have osteopenia. Some of you might have been told you have osteopenia via your GP or your endocrinologist. And this is a key kind of thing to know about. Okay, we'll get to the diagnosis of this compared to this, but this is a key thing to know. It's a bit of a flag, a bit of a red flag. If you have this, then you should probably be doing something about it, and that can help prevent you getting to this, because this is really where the fracture risk starts to amplify. Okay, 66% of people over the age of 50 have osteopenia. And so a lot of these people aren't aware that they have it. It's a silent condition. It's very different to osteoarthritis, which of course, osteoarthritis is more of a joint condition that has more of a pain and dysfunction profile. So very different. People generally will know about it more likely if they have osteoarthritis, and they may not know about it if they have osteopenia. It definitely affects women more than men, which we'll get to in a moment. And it's an extremely costly condition. So a NOF is a neck of femur, fractured neck of femur, and it can cost approximately, so on average, $30,000 for a given fractured hip. And 50% of people that fracture their hip never return home, which is a really sort of concerning, scary statistic. Obviously, a lot of people who are fracturing their hips are probably, quite often doing it in their older years. So there might be a lot of other comorbidities that are preventing them getting home, but it's still an extremely concerning statistic and something that can be, reduced considerably with appropriate management. So we'll certainly get to that and all the positives that can come out of the new research that's coming out in the last 5 to 10 years. So yeah, the last point there, trabecular bone over a cortical bone. This just means that the bone loss, the reduced bone mass and bone mineral content of the bone is more pronounced in the trabecular bone versus the cortical bone. But it does occur in both, and we'll kind of continue to come back to these different components of bone anatomy as we go along. So why does osteoporosis occur? First thing to note, which is not written here, is essentially that as we get older, we're losing bone mass, particularly beyond our sort of, 20s and 30s. We're sort of losing bone. as a normal part of aging, really, every year, on average. Um, but that doesn't mean we can't do anything about it. Essentially, what's happening is there's a higher rate of bone breakdown versus bone formation. So we have these cells, bone cells called osteoblasts and osteoclasts. So osteoblasts form bone, and osteoclasts sort of degrade bone down, which is actually an important healthy process to initiate actual bone remodeling. Which is this is what healthy bones do. They're kind of forming bone and breaking bone down. These cells in a pretty in a pretty proportional way. And osteoporosis is essentially more breakdown than formation. There's a few sort of pathophysiological mechanisms here. So patho just means, abhorrent somewhat, pathological physiology. So one of the key ones that you've potentially heard about is a hormonal change. After menopause, women will have a reduction in their estrogen levels, which is um, it's very significant, and estrogen's got a very supportive function when it comes to the formation of bone. So, when we have a good level of estrogen in our system, it helps to inhibit some of the resorption that's going on, the breakdown. So when we go through menopause, women lose a degree of estrogen, obviously, and that can really sort of exacerbate bone loss. We can have low calcium levels for other reasons. So this can be due to absorption problems in our gastrointestinal system. Various metabolic issues can drive low calcium. One of the things can be sustained corticosteroid use. So this is a drug that people might be using for inflammatory conditions like rheumatoid arthritis. They might be using it for respiratory problems like chronic obstructive pulmonary disease. Steroid puffers if they use them for many many years, and that can really affect again calcium absorption and metabolism that is important for bone health. Thyroid dysfunction can be quite key, particularly if you have hyperthyroidism, because high levels of thyroxine can interrupt this balance as well. Um, and finally, malnutrition. So if someone's got celiacs, they might not be able to absorb or even eat enough of the right nutrients, calcium being one of those. So I just want to double check our chat and see if anyone's. So it looks like everything's okay. Moving on. So this, on one hand, this is quite a simple thing, but on the other hand, there's a lot of complex causes. So we're not necessarily going to be able to get into every level of those tonight, but it's worth just touching on some of them. There is established risk factors for osteoporosis. One of them is obviously age. We all lose bone mass as we get older, not just women, but men as well, but females particularly. And post-menopausal loss is a key driver there. Family history. So if your parents and grandparents had lower bone density, it's more likely it'll affect you. Calcium and/or vitamin D levels. I mentioned before corticosteroid use, hormonal levels, particularly of estrogen, thyroid conditions. So hypothyroidism can actually lead to the supplementation via medication, and that can then have its effect on bone in a sequelae sort of sense. Um, yeah, any sort of inflammatory bowel or absorption issues in the gut can be linked with the condition. Rheumatoid arthritis, primarily because of the changes around joints and the bone changes around joints, but also because of steroid use for the pain. Liver and kidney problems, and ethnicity. So certainly Asian and Caucasian people are much more likely to get bone loss or lower bone density. There are things that I've highlighted in bold here. It's a pretty boring slide, obviously, but these factors here are things that we can change, which can influence our bone health. So certainly lower physical activity. So we can increase this in an appropriate way, and that can really help with our bone health. Smoking is not good. So and alcohol is not good. Neither of these things are good for any sort of part of our physiology, but certainly smoking is a big one. Weight. Sometimes people can get low bone density because they're underweight. So that's probably something that's relevant, um, as opposed to other conditions where too much weight is obviously a problem. However, obesity can impact hormonal balance. So that's got its potential problems with bone density as well. So moving on to diagnosis. So some of you probably have had some bone mineral density tests done. Um, there's two ways to diagnose osteoporosis. One of them is with bone density, the densitometry that you can get done, and another one is simply due to having a minimal trauma fracture. So minimal trauma means that it's something that wouldn't probably cause a fracture in someone with healthy bone. So again, standing from a falling height is a good example there, and that's when people might fracture their wrist or their hip or their spine for that matter. These are the three common areas that are fractured with minimal trauma. You can see over here, this is just a kind of a good visual representation of a bone with lower bone density on the right. You can see that sort of trabecular bone is less dense. It's kind of less, you've got less of that strong lattice look to it. It's a bit more kind of that Swiss cheese, larger holes in the matrix, whereas here is a nice healthy bone. So that's just sort of a good visual. Anyway, moving back to here, we've got two criteria for diagnosis. So minimal trauma, yeah. If anyone has questions about this, please let me know. Sometimes the categorization of a minimal trauma fracture can be somewhat, grey. We get people come into the practice with a broken bone who have been diagnosed with osteoporosis who might tell us that yeah, they might tell us that, they had this fracture and there was high energy in the fracture, and it seems like that makes sense. But then, they've been diagnosed with osteoporosis because it was deemed minimal trauma and there wasn't enough sort of force, involved. So sometimes that can be a grey space. So yeah, any experiences you might have are quite, quite interesting there. BMD is obviously the thing you've probably heard of. Now, there's various numbers that come with BMD, and these are to do with T scores, these numbers, for diagnostic purposes. And essentially, these are standard deviations away from, the mean. So you can obviously see these are negatives. Um, and above -1 sort of gets us back towards zero. And the further we get away from zero into the minus, we're just getting more standard deviations away from the mean. So obviously, the further away we are, we're in that osteoporosis category. And the osteopenia is a bit of a red flag because the trend is often continuing down. Okay, so we tend to get a score for these things in both the hip and the spine. So I've got some examples here. I hope this is not too hard to see. But if we start on the right here, I'll go through T scores and I'll go through Z scores and I'll touch on TBS scores on the next slide. And this is actually a fracture risk assessment metric that's used to help people ascertain whether they are at an increased risk of fracture. So if I can sort of zoom in a bit here, I think this should work. So this is someone's bone density here, and you can see we have I've crossed out the names. Hopefully we don't have any privacy issues. This is the lumbar spine measures. So this is your lower back vertebrae. Okay, L1 to L3 here at the top, and L2 to L4. We have 5 lumbar vertebrae, so they've included 4 of them in this assessment, and they give a number in terms of bone density, grams per centimeter squared, and then that correlates to a certain amount of standard deviations away from the mean. Now, this is the mean for a healthy young female T score. Z score is compared to a female the same age. So T score is compared to a young female, and Z score is compared to a female the same age. Now, we'll have similar scores for males, and obviously the grams per centimeter squared is more going to be linked with males. So it's all to do with averages, and that's a key thing to understand, I think. You can see this person, they had a bone scan done, a bone mineral density done at some time in the past. So these are the numbers compared to then in a percentage amount. And then this is the change since the previous BMD. So slight reductions here, 2%, 1%, not too bad. So if we go back to our previous slide, these numbers here basically put this person into osteopenia. Sorry about that. If we go back here, those numbers were in this middle zone. So you can see they are lower than -1, but not as low as -2.5. Okay. So that's kind of a key thing to understand. Sometimes you'll get this sort of comment here: mild degenerative changes are spuriously elevating lumbar spine BMD, especially L4. So sometimes that can happen. You'll have one vertebrae that might have more arthritic degenerative change, and arthritis is characterized by increased bony buildup on the around the joint, and that can make bone density look higher. So it can kind of give you a false reading, like a false positive that it's reading more strongly. So that's why L1 to L3 is probably a better indicator here because it's excluded L4. Okay. So that's T score and Z score. We can come across here to the hip. This is for a different person. I'm sorry, this is a bit grainy, not a very good picture, but you can see this person is more in the normal category here. So minus 0.7, -0.4 for the left and the right neck of femur. So quite a normal T score. We wouldn't give that one too much worry. We need to acknowledge all of the parts to the scan. So generally, as our T score goes down and our osteoporosis, category comes into play, the further that goes away from zero, there's an exponential increase in fracture risk with reduction in T score. So it really is key, and really important to understand. Touch a little bit on fracture risk. You will see this sometimes on some bone density scans. Sorry about that, everyone. If I can just get my Zoom happening. So sometimes they'll give a bit of a fracture risk here. Okay, 10-year absolute fracture risk, World Health Organization fracture risk. So this is really a bit of a combination assessment. Takes into account the scores here, takes into account the trend of the scores, takes into account the person's age, history of fracture, family history, if their parents had a fracture. So the fracture risk is actually, the FRAX is quite a useful thing to use. Oh, my apologies again. This must be driving everyone mad. The fracture risk tool is quite good. You can actually go and do that online if you like. If you've got concerns about your own fracture risk, you can go in, particularly if you've got a bone score, a BMD score, you'll be able to plug in some numbers and your details, and it'll give you it'll give you a bit of a percentage. So I think that's a useful thing for a lot of people to do. Now let's get into the TBS. So the TBS is the trabecular bone score. So the BMD scores that we talked about a minute ago, the T scores, they don't really perfectly predict fracture risk, and they only account for about 60% of the variation in bone fragility or fracture risk. So the TBS is just another sort of assessment tool, and it really is providing further information about the microarchitectural integrity of the trabecular bone. And again, if we go back to that earlier slide, the trabecular bone can withstand higher strain, and it's really a good indicator of how strong the bone is internally. And you can see here, this person, the trabecular bone score is really quite low. Okay, it's well into the red area here. You can see back on this previous one, we have a trabecular bone score of 1.21, and we have normal is more than 1.33. So that just means there's partially degraded, matrix of the trabecular bone for the vertebrae that have been assessed. Okay, which is L1 to L4. We don't use TBS to diagnose osteoporosis. So the diagnosis again is based on the T scores and or and or minimal trauma fracture occurrence. So moving on, assuming you have a diagnosis, perhaps you have visited the question of medications with your doctor or not on your own. There's a couple of different categories of medication options, and I want to start by saying medications are still quite a very important management intervention for a lot of people. So many people really need to be on medications. That's not to say that there is plenty of grey space, you know. So we'll get to this gradually over the next few slides. So there's a category called anti-resorptives, which really suppress osteoclastic resorption. So this is where we're suppressing the bone breakdown through these drugs by various means. You know, HRT is a common one that's prescribed post-menopause to help replace the loss of estrogen. It comes with its issues. There's increased risk of cardiovascular problems with hormone replacement, but it does have quite an impact on bone health. So it's got its place for a lot of people. There's the category called bisphosphonates. Again, these have um, an effect whereby they suppress osteoclastic resorption, which is reducing breakdown. So you might have heard of Actonel, Resendronate is the chemical name, Zolendronate, Aclasta, and alendronic acid, Fosamax. So these are common ones that we come across that people are using. And then there's a rank ligand inhibitor called Prolia is the common one that we hear in Australia a lot. Denosumab, sorry. So lots of different options here. And the best person, it's certainly not my area of expertise. The best person to be talking to about this is an endocrinologist or a well-equipped GP who understands osteoporosis well. The other category of drug is more anabolic type agents, which help to build bone. So they're supporting the osteoblastic cells to help build bone. So there's parathyroid hormone, these options here, Forteo and Timlos. There is a sort of a new kid on the block called Evenity, Ramosozumab, which actually has a function whereby it does a bit of both. It has an anabolic sort of building component, and it has an effect where it also suppresses osteoclastic resorption. So this is a bit of a drug that's pretty popular right now. It does have its side effects as well. There's some cardiovascular issues associated with it, but it's been strictly sort of used at the moment for people with severely low bone density and people that have had minimal trauma fracture. So you may have come across this, or you might have friends who have. So medications, the good. There's good things about them, obviously. Generally, on average, you'll get a 5 to 15% improvement in bone mineral density and a 30 to 50% reduction in fracture risk. So these are pretty good numbers generally, but they come with some cons. So there's generally poor compliance because people struggle with the side effects. So 1 year compliance for medications on average is 50%, which is not great. So if you've got someone with very severe bone loss and a high fracture risk, and the compliance for the medications is not there, then the risk just goes up further, particularly if medications has been the avenue of intervention and there hasn't been something else, e.g. exercise, thrown into the mix to help. There's also 40% of non-responders. So, you know, that's a lot. That's 2 out of every 5 people who go on these medications won't respond and won't get the BMD improvement and the reduction in fracture risk improvement that we see over here. So I think that's some scary numbers and sort of really worth noting. The side effects are quite varied, and there's lots of them, and there's lots of them beyond just this here. GI effects and vomiting is pretty common with bisphosphonates. We have cholesterol issues with Prolia, osteosarcoma, which is certainly a very concerning thing with teriparatide, and there's some increased risk of breast and ovarian cancer with hormone replacement therapy. So certainly, medications are very important on one hand, but have their problems on the other. So I think that's a really key thing to note. Okay, moving on. So it's probably time I really want to talk about loading versus unloading. So I think the thing to I think the thing that people don't realize with bones is that they're a bit like other tissues in the body in that they respond to their stimulus. So, we know that when people go into space and gravity is eliminated from uh, as a force on their skeleton, they lose bone mass considerably. Their bones get very weak and very fragile. Similarly, with someone who might be immobilized, wheelchair bound, or bed bound, they will actually lose bone mass very severely in the areas of their body that are not being loaded. So I think that's something people forget, I think, in that bones are very responsive to their stimulus. On the other side, we have a loading effect. So we've all seen Rafa Nadal's tennis arm. It's genuinely thicker and bigger than his other arm. And there's some research that's really quite profound that shows that elite baseball pitchers have a much thicker bone in their throwing arm, like very significantly thicker in its density and in its size. So bone does respond, in the same way muscles respond. It's just a little slower. So we'll get to that in a minute because it's a key part of what you can do. Now, exercise, I suppose, for bone density has always been this ancillary therapy for osteoporosis, this secondary option. And the question about that is around that is why. And I think in the past with research trials, they were they were never structured in a way where higher loads were used. So the magnitude of load was very low. So that was poor trials in the sense that we know now that bone needs quite a lot of load to change. So we'll get to that on the next slide. So there was many studies done that showed kind of these small tenuous benefits from exercise. And because of those trials, it was never fully adopted by the appropriate medical, professionals. There's also anticipated poor adherence to exercise. So, the amount of times I suppose GPs or endocrinologists might encourage people to get active and start to do things for their health, people don't necessarily follow the advice and the exercise doesn't get done. So then it's perceived as an ineffective sort of avenue to take. There's always been this fear of fracture from medical professionals to then push people into exercise, which is very understandable. They're worried about people's fragility. Unfortunately, this has kind of the exact opposite effect because if the medical professionals involved are making people more fearful of exercise because of fear of fracture, it just sort of perpetuates the problem. So that's the real challenge, and that's where supervised structured exercise has a big part to play in this population. And just generally knowledge about exercise training and where its place is. I think plenty of doctors aren't necessarily trained in that area, so they don't push people down that avenue for management. So four pretty key areas why it hasn't been a big option in the past. So bone does require quite high strain and high strain rates, so the speed of loading to respond to be osteogenic. We know that things like walking is okay for bone, but it doesn't necessarily stimulate more bone. So walking is obviously a higher repetition, low load exercise. Other people also sort of think that they're lifting some weights. It must be doing some good, but often they're lifting 1 or 2 or 3 kilogram weights, which are really, again, that's a low load and it's a high repetition weight. So it's not really going to have any impact on osteogenesis, which is what we need to strengthen the bones. So we need more strain. So we need resistance, we need load, and we need more strain rates. We need more speed of loading. So these two things together can stimulate osteogenesis. The thing about exercise as well is it strengthens the muscles, which pull on the bones, which again adds another force to help them adapt. And beyond that, our muscles are really good at absorbing and attenuating forces in a given situation and perhaps in a fall or in other life moments. So we make muscles stronger with exercise. We don't make muscles stronger with medications. So I think that's a key thing to understand is that you can adjust bone strength through exercise, and it's got this kind of myriad of further benefits. beyond just improving the bone density. So let's get to lift more. So some of you have come across lift more before. I'm sure for some of you this will be new. The lift more trials, in particular this top one here, were quite groundbreaking. So the authors here, yeah, this was regarded as one of the kind of key, key findings in osteoporosis in the last 20 years, and this study was quite highly regarded. So essentially, you can see the title: high intensity resistance and impact training improves BMD and physical function in postmenopausal women with osteopenia and osteoporosis. The Liftmore randomized controlled trial. So you can see that it's a randomized controlled trial. That's the best quality of evidence we have. You might have heard of a systematic review. That's the best, and that's when all of the randomized controlled trials are collated for a given question, to answer a given question. So this was a trial conducted over 8 months in postmenopausal women. It was done twice a week and only 30 minutes per exercise session, and the resistance was high. So they had heavy lifting, 85% of 1 RM, and this equates to around the weight that you can only lift 5, maybe 7 times. So it's quite a heavy load, it's quite a heavy load, and that's really important. It can be hard to get to this in time, but you can. Beyond that, the participants did impact exercise, and the key part as well was that it was highly supervised as far as the technique and the progression went. The results were really quite groundbreaking in that there was a 4.1% improvement in spinal BMD and a 2.6% improvement in hip BMD in the femoral neck, which is where fractures occur. And this is a really important finding in that there was a 27.1% increase in femoral neck cortical thickness, which is exactly where fractures occur when people fall and fracture their hip. There's also improved function, so strength, mobility, balance, posture, which people are surprised by, which is amazing, mostly through to muscle recruitment in their back and functional reach. And there was a negligible amount of injury. Now, this was repeated for males in this trial here, and similar results were found in men. Okay. But obviously, this was the bigger one because osteoporosis affects women more. This led to Onero. So Liftmore was conducted, and the results were quite staggering and very good. So Onero was then formed, which is an exercise program. Now, Onero means load in Latin. I think of the word onerous, I suppose, but people often think it's an acronym for something. No, it's a word, and it's formulated by the Bone Clinic, which is a research group from Griffith University, Queensland, following the results of the Liftmore trial. So Liftmore was basically, the results were so good that it was put into clinical and real life practice via an appropriate protocol. So this is research directly into a program, which is great. It's kind of the definition of evidence-based practice, which we don't always get in medicine. And physiotherapists and EPs like us can be accredited and trained as licensees of the program. And we need to sort of implement it with a high degree of fidelity. In the real world, with sustained Onero participation, we can get even more improvements than this. This is our 8-month results, which were very good. And this is our real world results in that we can get up to 20% improvement. We get a better response rate than medications, and we can get up to 90% reduction in fracture risk from falls. That's what the research is showing, the progressive research beyond that Liftmore trial, which is amazing. And again, this is because the bone density can improve, but also muscle function, muscle strength, balance, all the things that can contribute to fracture risk. All of those things can be improved. At St Leonards Physio, we're running a lot of classes at the moment. It's quite a I guess a popular and effective program, which makes sense based on the research. Many of you might have met the team. This is Hu Chang, this is Jack, myself, and Michael. And together we've been running the program for quite some time. Generally, if you're interested, you'll need an initial assessment to ascertain your starting point. Many people can go straight into classes, and some people may need some one-to-one sessions to get going. We run generally the program where you need to commit to twice a week, and there's 60 minutes per class. So it really is quite an involved program. It's 20 classes over 10 weeks, and we run them in terms. We have many different class options, and there's 6 people per class, which I haven't put on there. It's quite an individualized program. What I want to talk about now is stop fracture, which is a research trial that's currently happening right now, aiming to prove the effectiveness of neuro in reducing fracture. And the idea here is that the Bone Clinic are aiming to get Medicare subsidization for Onero participation in the future. So in the same way diabetes and other chronic diseases have Medicare subsidies involved, we're trying to together we're trying to get this available for osteoporosis. So this is currently available for the right people. There's a $20 per class subsidy for up to 6 months until the end of 2024. It doesn't cover any initial assessment cost or one-to-one sessions, however. You do need an appropriate referral. We can help you. We can help you acquire this if you like. There's a few inclusion criteria. You must have low bone density and/or a minimal trauma fracture history. Unfortunately, for those of you who are already doing neuro, you can't get the subsidy if you're already doing the program because it will affect the research trial results. So I'm sorry about that if you are in that category. Now, I'm just conscious of the time. It's 10 to 8, and I just wanted to go through some of the exercises that are part of Onero. The deadlift is a kind of a foundation exercise that we do, and we always do this essentially at the beginning of the class after we've warmed up. So you can see here, you can see A correct, B incorrect, and you can see another image down the bottom here. The deadlift is really a way to load the body up quite heavily with a barbell, and the bar sits on the ground. And you can see here there's a lot of angle at the hip joint, and there's a nice flat back, and the head and the spine are also in a nice sort of position, which allows the hips to lift really strongly and effectively. Now, we start the weight very light here. Some people will get a bit worried about the look of this. We start the weight very light, and we gradually build things up, and your body will adapt as it's slowly exposed to the load. This is a more traditional looking deadlift, and we don't do this so much because it loads the knees more and it doesn't load the back in the way that we like. This is the way that really builds the spinal load up and helps strengthen the bones and the muscles. It's worth me just mentioning before I go through all of these exercises that these are the exact things that were done in the Lift More trials in postmenopausal women to quite a heavy load when it was safe to do so. You can see this is being lowered down now. It's kind of coming down towards the floor, and the woman's keeping her back nice and flat as she folds at the hips. She's also securing her shoulders and head in a nice position as that goes down. We try not to round the shoulders down. We try and keep that open chest sort of look. So that's the deadlift. Everyone will learn that if they do a neuro. The squat is another key part. You can see this is a picture where the woman's doing a back squat. The bar is on her shoulders here, and her heels are actually being elevated. This allows some people that have like a stiff ankle maybe, or a certain body type, this allows them to squat down a bit deeper. So the back squat is, this is a barbell in the same way that this is a barbell. And we tend to add weights to the side of this to try and build the load up when it's safe and the person's doing the exercise well. These are introductory versions that we get people to do when they're learning. So this is a counterweight squat with a banded assisted descent. And we have a weight here which helps to counterweight this woman as she squats down, counterbalance. So squatting is a key part of a neuro as well. We have an overhead press, which is obviously an upper body arm movement. Key thing is this elbow forward position with the bar across the collarbone line, and then we push the bar vertically up past the face over the head. And again, we try and add weights to this in an appropriate way to get it to a heavy point. The drop chin, this is actually the impact exercise involved in the program where we the body is pulled up and people then land heavily on the ground. So it's a bit of a chin up in a way, but we allow, people often need to jump up a little bit as well. And then the idea is you actually land quite heavily on the ground to get some impact through the legs. Again, these things are all done in a quite a graded, slow way, but they're very effective if they're done appropriately. So I'll just go through a few of my sort of thoughts around the program and this condition just before we wrap up and I get some questions from you all, if there is any. I think the key thing with the program, I suppose, and the exercise, which is really what I'm advocating strongly here, is people do feel the benefit after enough time, I suppose. So it can be quite a daunting program to start, particularly if it's very new for you. You learn a lot quickly with your experience of it, but you will actually feel better. 9 out of 10 people will feel better in this period of time. And then they often will then start to report to us that in the real world, they're doing things more easily on a functional level. So the other day, someone mentioned that they're hiking much more efficiently. And they can climb stairs and hills a lot more strongly and powerfully because their legs are better, legs are stronger. So that's just that's a key thing that we love hearing, and it's really tangible and it's really common. People doing the program report improvements there. There's a lot of benefits beyond bone density, so we try not to dwell on the T score too much. We actually think it's best not to focus on it, particularly in the short term, because the benefits of all of the other benefits are probably just as important, and you'll make more impact on your bone density with more sustained time, years really. So that's when you've kind of got to start to consider this and understand this is a lifestyle change, not a temporary dose of intervention. The program helps people get to the World Health Organization's guidelines for exercise. I try and remind people of that. You get a lot of exercise in the 2 sessions each week. The more consistent and long the stimulus, the more potential for change. Medication is still very important. So I didn't want to give the wrong message there. It's very important for many people, and it should be used a lot of the time alongside exercise. And finally, some comments about pain and injury. Plenty of people will get some pain when they commence some of the exercises, and it's really important that we navigate that gradually with people. And we're pretty equipped to modify and adjust accordingly. So I just try and explain to people that it's not um, it's not always feasible to be totally pain-free when you're trying new things. But we minimize risk of injury as much as we can. So yeah, I think it's important to just yes, sort of have an understanding there that it's not always this linear perfect introduction if it's new for you, these types of exercises. Anyway, I think we're coming up right on 8 o'clock. I'm going to stop sharing my screen